Molar pregnancy is a type of gestational trophoblastic disease. Gestational trophoblastic disease includes complete mole, partial mole, placental site trophoblastic tumor, and choriocarcinoma. Molar pregnancy is an abnormal form of pregnancy in which a non-viable fertilized egg implants in the uterus and will fail to come to term. A molar pregnancy is a gestational trophoblastic disease which grows into a mass in the uterus that has swollen chronic villi resembling grapes. You can see on the right side, these are chronic villi resembling grape-like vesicles, and molar pregnancies are characterized as either partial mole or complete mole. Here you can see an example of a partial mole. A complete mole contains no fetal tissue. It happens when an empty egg gets fertilized by 1 or 2 sperms. 90% of the time they are 46XS and 10% of the time they are 46XY. Whereas a partial mole occurs when a normal egg is fertilized by 1 or 2 sperms, which then reduplicates itself, yielding a genotype of triploid or tetraploid. With a partial mole, fetal tissue is often present. Fetal erythrocytes and vessels in the villi are a common thing. Here you can see an example of partial mole. Hydatidfrom mole is more common at extremes of reproductive age. Women in their early teenage or perimenopausal years are at most risk. Women older than 35 have a 2-fold increase in risk. Women older than 40 years experience 5 to 10-fold increase in risk compared to younger women. Parity does not affect the risk. Molar pregnancy occurs in 1 in 1,200 pregnancies. Signs and symptoms of partial mole and complete mole. Actually, based on the signs and symptoms, we cannot differentiate between a partial mole and a complete mole. For differentiation, we have to do a pelvic ultrasound. So here are some common signs and symptoms of complete mole and partial mole. The uterus size would be larger than expected, ovarian theca lutein cysts, hyperthyroidism symptoms, beta HCG level high, hyperemesis, most probably reactionary to the high beta HCG levels, vaginal bleeding. Patient may complain of passing grape-like vesicles, and high blood pressure. Here on the right side you can see ovarian theca lutein cysts. These are a rare type of functional ovarian cyst. They are associated with gestational trophoblastic disease. Workup: serum beta HCG, thyroid function tests, complete blood count may show anemia due to heavy vaginal bleeding, liver function tests, blood urea nitrogen and creatinine levels, blood type and Rh factor. Pelvic ultrasound is the main diagnostic modality for molar pregnancies. In complete mole, you will see a snowstorm appearance. Here on the right side on top you can see an example of a complete mole, and on the down you can see an example of a partial mole. Here you can see a growth retarded fetus and cystic placenta. We'll also do a chest x-ray and histology of the product of conception. Chest x-ray, because this invasive type of mole, they like to metastasize in the chest, so a chest x-ray is important to rule out any metastasis to the chest. Management: symptomatic management, such as if the patient is anemic, we will treat her anemia, and if the patient shows symptoms of dehydration due to hyperemesis, we will treat that. And if the patient shows symptoms of hyperthyroidism, we will treat her accordingly. Administer Rh immunoglobulin to non-synthesized Rh negative women. Evacuation of the uterus by dilation and curettage or suction and curettage is always necessary. On the left side you can see an example of a suction and curettage. It is usually done under the guidance of an ultrasound to avoid the rupture of the uterus. The patient is instructed not to become pregnant for 6 months. Effective contraception is recommended during this period. Monitor serial beta HCG level to identify the rare patient who develops malignant disease. Normal beta HCG levels are usually reached within 8 to 12 weeks after evacuation of the Hydatidfrom mole. As long as the beta HCG levels are falling, no intervention is needed. Prognosis. Because of the early diagnosis and appropriate treatment, the current mortality rate from Hydatidfrom mole is essentially zero. Approximately 20% of the women with the complete mole develop a trophoblastic malignancy. Gestational trophoblastic malignancies are almost 100% curable.